Hello, this week we'll talk about topic 10, hurting, pain and its reverberations. So pain, of course, is very important for us. It's our body's alarm system, sort of like our emergency alert. Our bodies have to let our brain know what's going on so that we can take action. So they communicate the presence of a problem very effectively via a quick-acting, straightforward, unambiguous messaging system, pain. Of course, it's then incumbent on the CEO, which is you, to decide what to do about it. Pain keeps us out of danger, so we can change behavior. Retreat from painful stimulus. So if you're running here and doing a motion that's starting to cause damage to your body in some way, then pain will be the indicator that you will stop running in that way. Likewise, you'll withdraw from a painful stimulus, just like this child lifts his hands from a fire. So pain has a very valuable place for us, and that's what we'll investigate today. So pain ratings come to be very important for treatments in which the cause of a condition is not readily apparent. A pretty common condition, actually. And so rating on a pain scale is often how it's measured. So you might be asked a question like, did you have pain today? Did you avoid or limit your activities or cancel plans today because of pain or changes in your plan? Did you take all your pain medicine today according to instruction? This will become very important, this series of questions, especially these related to medication, when we go into our next content on addiction, where we'll take a look at what's exactly happened in terms of pain treatment and its negative, problematic repercussions for addiction. But nevertheless, doctors, nurses have to get a sense of how much pain a person is in order to treat them appropriately. And this pain can emerge from many sources. So overuse, repetitive motion, injury, things like arthritis or other chronic conditions, cancer, illness that are coming on and causing destruction somewhat more suddenly. Aging can have a consequence of pains, just as the cushioning between our bones or within our joints comes into becoming worn out. And of course, just a general lack of care for our body can lead our body to send us signals of pain, where you're not exercising enough, you're not sitting up properly, you're allowing the muscles in your back to get weak, and so forth. Reporting pain becomes pretty important, actually, and I don't know if it's really a funny story of my daughter and a podiatrist, and this happened about 8 weeks ago, I think. So my daughter had a long-standing injury to her ankle in which she tore a ligament, so her foot kind of sits funny. So when someone looks at her ankle and foot in a relaxed position, it's kind of arced over. So it looks a little odd. But that happened 15 years ago, and irrespective of that, she injured her foot in some way. I can't even remember how. And over the next couple of weeks, it seemed to be getting worse, not better, and it really was hurting. And eventually she decided to go see a podiatrist, or a doctor who studies feet. And he noticed her odd sway of her ankle. And maybe he got sort of focused on that, because she actually went to see him because her toe was in pain, but she mentioned this injury to him, and consequently it's like he did not even touch her foot during this visit. He just said that she needed to have I don't think her toe, this is not her foot, I don't think her toe was, I don't know how black and blue her toe was, but she went in with pain to her toe. And so the doctor prescribed that she needed to have an orthotic, which is like a custom-made insert that would go into her shoe. And so she said, oh, okay, I'll get an orthotic, and he wouldn't x-ray it, and he didn't touch her foot. And after she wore this orthotic, she discovered that it was actually getting still worse and not better. So she went back again after about a week and told the doctor it was getting worse and not better, and he urged her to be patient. And finally, she said, I would just like to have an x-ray. And so he really actually balked at that, but finally he did an x-ray and he came back in with the scans and he's like, well, I don't know what to say about this. He said, you actually have a broken toe. I mean, this is quite serious. This is kind of late for you to be coming in. You might have to have surgery. So he was really quite taken aback. And later on, when this issue came up, he said, well, you usually when people have a broken toe, they're in a lot of pain. And she said, well, I was in a lot of pain, but evidently he did not give her a pain rating scale. And so the way she described her pain apparently didn't communicate properly her problem. It is important to communicate your pain and to be accurate. And if you exaggerate your pain, you might get caught in this trap of medications that can lead to addiction, although I think doctors are avoiding that much more strenuously now. And if you underestimate your pain or don't somehow communicate it, then you run the risk of not having an x-ray when you need one. And thankfully, she went to another place and did get proper treatment, and she did not need surgery. But yeah, pain, the body's alarm system. She was listening to it. And then the breakdown for her situation came in communicating it to the doctor. So we have a few categories of pain. So we have acute pain, and we would describe acute meaning it's sharp, intense, it's sudden, it occurs immediately in reaction to an injury. You might think of it as, when you wham your knee into a coffee table or something like that. It's sharp, it's acute, it's intense. Usually it passes quickly. Depending on the nature or the cause of the pain, it can last longer, minutes, hours, days, but most certainly less than 3 months. For acute pain to last anything like 3 months would be a pretty serious injury. Chronic pain, on the other hand, that's the kind of thing that it's really hard to communicate. It's not so sharp and intense that it like deactivates you, but it's sort of constant. It's kind of nagging. It slows you down in a general level. It interferes with your sleep. You can put your hand on where the pain is in a kind of a general way, but not maybe that specific. And so a lot of times people experience chronic pain in their backs, or perhaps knees, or perhaps hips. And this chronic pain and the treatment of it is what led to a large part of this opioid epidemic that we will examine more closely in our next class. Now, that is different from chronic malignant pain. Malignant is a word that refers to likely to cause death. So, for example, a malignant tumor, there are many kinds of tumors, and a benign tumor is one that can be removed. It's not spreading to the body, but a malignant tumor is one that has spread to the body and that may in fact cause death. And the pain that accompanies that is pain that's going to continue to get worse as the disease worsens. Generally, treating this kind of pain, doctors will give whatever is needed because in this situation, the purpose is to make that individual as comfortable as they can be in their coping with this disease that may end up in the loss of their life. So there are different origins of pain as well. Psychogenic pain, genic just means the genesis or the beginning of the pain is psychological. Psychogenic, generated by the psyche. So there's no physiological basis ostensibly. So the doctor can't figure out why this person is hurting, so they kind of say it's all in your head. And there is such a thing as psychogenic pain. In fact, some people might say that much of the pain that we have in our bodies comes through our psychological manifestation or say, the holding of certain emotion or grief or something like that. Somatic pain is physiological pain in a region of the body without tissue damage. Okay, so the pain is very localized, but you can't detect damage to the tissue. And then neuropathic pain, another term, pain that emerges from damage to the nervous system, resulting in painful sensation from non-painful stimuli. So each of these are slightly different. So when there's neuropathic pain, since it's coming from the nervous system, this can be really hard to detect for a doctor, and it can make a person very sensitive to just the slightest touch or a rubbing or a sensation on the skin can really have, the individual can have quite a painful response from that, because their nervous system is what's generating the pain. So these are just some different categories or ways to think about pain, and these can easily be confused. And pain that might come from an autoimmune condition, which we haven't yet studied, that can often be misdiagnosed when the doctor can't detect a specific cause for the pain. So what is pain exactly? So at the physiological level within the body, the function that we have is nociception, the reception from nociceptors. So these are specialized nerve fibers and receptors that respond to noxious or harmful stimuli like heat, cold, pressure, or chemical stimuli. So these are just a particular type of receptors that respond to particular triggers that are harmful for the body. They signal the occurrence of tissue damage. That's what they're responding to. And they don't always result in the experience of pain, because the experience of pain is subjective. So even if two individuals are having nociceptor action that might be similar in terms of its electrical energy, they still might not have the same report of how much pain they're in, because people have different sensations for that. And of course, all of these are traveling through the nerve fibers, through the CNS into the brain. By CNS, I mean central nervous system, which is like the pathway through which these messages are communicated. So the nociceptors stimulate autonomic nervous system action. And earlier, and perhaps with Dr. Sapolsky, we've talked about sympathetic and parasympathetic nervous system that happen automatically within our body. So we're not controlling these at all, and they're happening in response to stimuli. It could be emotional stimuli, or it could be other physical stimuli, like something that is an injury. And what's described here, the faster heartbeat, rising blood pressure, and sweating, this is all part of the sympathetic nervous system. So when you're in pain, your body responds throughout it with these physiological sympathetic responses. So earlier, we used to believe that when an injury occurred, there's like a one-way path. It's going like pain, here's the injury, and there it is up to the brain, one direction. Person says, ouch. But this didn't explain a few anomalies like the things in the points I'll make here. So soldiers in the battlefield who don't realize they're injured until the battle ends. This is called stress-induced analgesia. Analgesia is the numbing of pain, and it's stress-induced numbing of pain. They don't experience pain even though they might be badly injured. Pain that is experienced in advance of a potentially pain-producing procedure. So the dentist is about to drill your tooth but hasn't yet touched the drill to your tooth, but the individual has a pain response. Their nociception system is activated. This seems like psychogenic pain. It's like anticipatory pain. That one-way path doesn't understand pain that is relieved with acupuncture, a practice of putting needles into an individual to rebalance the meridians in the body. The one-way path does not explain exposure to pain stimulus with no experience of pain when a person is under hypnotic suggestion. So if someone is hypnotized, even if they're, say, poked with a needle or, they'll have no pain response, no nociception action. Pain that hurts much more for one person than another person. Doesn't explain that. A pain response that far surpasses the injury, what we call hyperalgesia. Algesia, again, the relief of pain. This is a hyper pain response. Pain experienced in a limb that has been amputated. This is phantom limb pain. And if there's no limb there, how can a person experience pain? So through all of these examples, we do recognize that there's a lot more to this than that simple model we thought at first. So this is a TED Talk. I'll invite you right now to stop. And you're probably not in the slides right now, but this is a video that you can go to through Blackboard or just by watching it within the slides itself. And so sometimes it's better to hear these experts talk about how these systems work than someone who's a generalist or not specifically focused on this area. So take a pause now and watch this 4.5 minute, almost 5-minute video. So now we'll look at some of those examples. So pain as a subjective experience. To quote, an unpleasant sensory and emotional experience associated with actual or potential tissue damage. That's what pain is. And this was a particular interesting study in which participants were invited to play a virtual reality game. So they're pretending to be characters, in which they were knights in a war. But even though the game was virtual, so they weren't really getting their bodies out there, participants received real electrical shocks when their virtual character was injured. So maybe that makes sense to you. So in the study, I have some images coming up here. In the study, the independent variable was armor on a virtual character. So their little character, so your little guy that you have, will either have armor or have no armor. So this is your guy with all kinds of protective armor, or this is your guy. He's got a cool outfit on, but there's no armor. Okay? He actually does have a little bit of armor, but he's not supposed to. He's not supposed to be having any armor, just the cool outfit. Okay? And the dependent variable is how much pain people report. Okay, so when their character's injured in this game, the person controlling the character is going to receive a shock. Their character will either have armor or not armor, and this is the result. The participants whose character wore armor reported significantly less pain from the same level of shock than those whose characters had no armor. So how is that for a bizarre study? Another condition that is unusual with respect to pain is called congenital analgesia. So congenital meaning you're born with it, it's in your genes, and analgesia, you don't experience pain. So to read the definition, it's a condition in which an individual cannot experience pain even if actual harm, like stepping on a nail or worse, occurs. So congenital, you're born with it. Analgesia, there's a dulling of pain sensation, but you're still conscious. And what happens is that small nerve fibers that normally transmit these nociceptive inputs malfunction, and so the communication between the source of the pain and the brain is disrupted. And so this person with all these things pulling on her is not experiencing pain. You saw this if you read the book or watched the movies, The Girl with a Dragon Tattoo, because this main character, Ron Niederman, had ostensibly in this book had this condition and could not experience pain. Now we do have different self-report experiences of pain by sex and ethnicity. So ethnic differences. We don't have, I'm sorry to say in this study, any reports of how Native people experience pain relative to what's reported here. So I'll ask you about this. But in experimental models comparing white non-Hispanic Americans with African Americans had higher pain unpleasantness, emotional response, and pain behavior, but no higher pain intensity. And when we ask why, the answer comes to that Dr. Sapolsky beginning, middle, and end, which is stress and oppression. African Americans with chronic pain report significantly more symptoms, and that's consistent with post-traumatic stress disorder and depression because of the way African Americans in our country are treated. Because of the stressful living conditions many, not all, but many are in, this creates this worse experience for pain that's exacerbated by less access to pain treatment through the medical system. We also have sex differences. Women also tend to report significantly higher pain levels, suggesting maybe a couple of things. It could be that they have more sensitivity to body cues, more body awareness, so they're also more aware of pain. It might be that they have lower pain thresholds than men for certain types of pain, specifically heat, pressure, and certain digestive and musculoskeletal conditions. In fact, women prior to the huge expansion of the opioid epidemic account for the majority of chronic pain cases. And if we ask why, we can say socialization. Boys are discouraged from reporting pain experience. This could be a part of it. So boys are taught to tough it out or to at least not admit to pain they might be experiencing. But let's take another little look at this. So on this slide, we're going to take a look at a study that suggests that males and females process pain differently. So just a little terminology, microglia are just cells in the white matter of our nervous system entirely that do many functions in our brains and nervous system, including working with the immune system. And similarly, T cells are another type of immune cell involved in producing antibodies. And so this is a study that suggests, in the end, that women process pain through T cells and men process pain through microglia. This may also account for different pain experiences for males and females. You can imagine why different processing modalities might be helpful, because women do have to cope with the pain of giving birth in order for the species to reproduce itself, and so there may be a need for different pain mechanisms. So the study was to stimulate the sciatic nerve. If you're not familiar with that, it's a nerve that runs down through the back into the upper part of the leg and down further than that. But people who are hurting very often experience pain in that side hip region. And so if you stimulate it, this is going to be a painful experience. So they would stimulate the sciatic nerve to get mice really so that they're experiencing pain. And when they stimulate that particular nerve, both male and female mice became hypersensitive to pain. And they did this not to torture the mice. Animal studies are always challenging to think about. They did it so that we could understand more about these different experiences in pain in males and females, looking at it in animals. So what they did, so both males and females have microglia, and both males and females have T cells. And so what happens in the mice if you block, in male mice, if you block microglia, the male mice is no longer in pain. What happens if you block microglia in females? They're still in pain. But if you block the microglia in females that don't have T cells, they don't have pain. So it seems that for females, these T cells are the dominant processors of pain, because the female mice were still in pain when they, even though the microglia were blocked. And so the suggestion from this is that males process pain through microglial cells, but females through T cells. just another explanation for why males and females may experience pain differently. So I've been giving you some interesting sort of information and strange descriptions of pain and different mechanisms, but now you have the opportunity to watch a very short but very worth it video with Dr. Elliot Crane on the mystery of chronic pain. And this is the kind of pain that has so many people experience that it's hard to talk about, and maybe you experience it. And this also, these experiences people don't want to talk about, this chronic pain. This is also what got us into the opioid epidemic. So take a watch of this video, pause this lecture now, open the video, watch it, see what you think about it. Next, we'll talk a little bit here about controlling pain. We're not going to spend super deep here because we will be talking a little bit more about this next week when we talk about the opioid epidemic as well as other addictions. So the gate theory of pain is what we can think about why the Band-Aid helps someone experience less pain. So we can think of we have two types of fibers to transmit pain to our brain. So if we have a really sharp pain, we have these really fast fibers. Like a race car, they zoom up to the brain and we feel immediate pain. And we also have slower fibers, large, long neurons that transmit less intense messages to the brain. And a toll gate here, endogenous opioids will block sensation of pain to the brain. So that's what this toll gate is. They're interneurons that transmit messages in between the source of the pain and the brain. So this toll gate could block all that pain. When one type of pain is going through, the other one cannot. And a consequence of this is that, for example, let's say you get a sharp pain. You just banged your knee on the coffee table, that thing we've talked about. It's acute pain. The race car starts on its way. There's your pain messages up to your brain. And so what do really naturally? You rub it. You put your hand over it and you rub it. And what you're doing is you're starting up these dull pain large neurons that send these slow messages. Your touch is enough to do that, and that essentially stops the pain sensation, because that touching, that rubbing that you're doing, you're putting your hand on top of that acute injury, you're rubbing it, you're getting those slow pain neurons going, which in essence blocks off the experience of pain from the acute region. Similarly, you could do the reverse of that. Let's say you have this dull headache that's been with you all day. Let's just move the toll gate up again. Here's this dull headache sending all its messages to your brain. Oh, it's just throbbing. And all of a sudden, you accidentally burn your fingers on your coffee cup or something like that. Well, you know that this acute pain is going to jump ahead and take over from this dull pain. And so, that's going to be essentially like this cessation of the headache while you're having the acute pain. So these endogenous opioids are these internally produced opioids. That's what endogenous means. Opioids are painkillers. Endogenous, generated within the body. So generated within the body are these natural painkillers that reduce our pain. So that was the way that I explained it. And now I'd like you to stop this lecture and watch the 6-minute video with a much better description of this process of gate theory. But I encourage you maybe slow it down a little bit. It's a really fast talking one, or maybe watch it a second time, because it's just sort of a fast talking little video, but a very helpful one for you. So what are these endogenous opioids? Well, they're analgesics, pain relievers that are produced in our body. We just went over that term. And they can be produced in the funniest ways, right? A Band-Aid can actually elicit the effects of these endogenous opioids. So the mechanisms in gate theory produce this, and so these are some of the other factors that can produce these. Our beliefs the way we think about something. So look at this weightlifter. If in his mind he's thinking, you know, oh my God, this is horrible, he's going to experience more pain than if he believes pain is gain. Then he's going to see the pain as beneficial. Think about it with respect to menstruation, which can often be painful, especially for young girls. But what does she believe? Has she had a ceremony in which she believes that menstruation is beneficial, meaning she's a woman? Or has she been told, oh, it's awful, you're going to have to go through it every month, in which case she might believe the worst of it and consequently experience more pain. Take this medicine. This is the placebo effect. So even if this is nothing but a sugar pill or an inert substance, but the patient believes in the doctor, he or she will experience less pain, will report less of a pain experience than someone not given these medications. So that's a placebo effect. Belief in the doctor causes reduction in pain experience. The hormone oxytocin is consistent with a reduction of a pain experience. And so as this woman holds her newborn baby, she may already have forgotten about that pain that she was in during the birth process just minutes before. Stress, this intense stress that this soldier is under, causes him to be unaware of a very serious injury. We already learned that acute pain can stop throbbing pain and the reverse. And of course, we sometimes take advantage of that. You know, we can pinch ourselves to relieve the pain of the menstrual cramps or whatever we might do. And we also know that, so some people are said to, there are many reasons why people get tattoos. For some people, part of the experience is the pleasure in the actual needles going into the skin, which then activates this endogenous opioid system and makes the person receiving the tattoo have kind of a nice experience. So some people also like that kind of experience. So managing pain can be done in many different ways. Most often in our country, it's done with a pill, but not always. I think our medical system is getting better. So there can be external physical management, like physical therapy. This person is trained with almost not quite the same level of training as like a doctor, but a pretty intense training program to work with people just doing physical things to relieve their pain. I imagine that this woman with a ball is having back pain, and that this particular move releases the pressure from her back and relieves her pain. Similarly, acupuncture, that's what you see in the needles in the second image, can just perhaps stimulate endogenous opioids or perhaps block the nerve. It's unsure why it works, so they might also be blocking the nerve transmission of pain, but acupuncture can also relieve pain, and people can even have surgery without pain medication and without anesthesia, simply by someone who effectively knows how to use these acupuncture needles. So chemicals, of course, exogenous opioids, the prefix exo meaning from without. So opioids, painkillers generated from outside the body. Acupuncture, which we just discussed. Surgery, of course, trying to physically change the source of the pain within the body through going in with knives or lasers. And there's also psychological pain management. So hypnosis, again, you already know that people, when they're actually having a painful stimulus under hypnosis, they don't feel it. So this can also be used to relieve pain in general. Distraction. If you're, in some sort of pain, you can take your mind off it if it's not acute pain. If it's acute pain, that will be very difficult. Cognitive methods. These sorts of things would relate to the beliefs that we discussed on the previous slide. So changing what you believe about the source of the pain can be beneficial, or the way you think about the pain. Things like virtual reality, which is similar to what's used to relieve pain from phantom limb syndrome. So changing your sort of your view on it and relieving it through an experience that isn't actually happening to your body. And then people can self-manage pain. So mindfulness training is a way of, it's a pretty powerful practice actually that involves training yourself to step back from the pain and observe it without resisting it, and try and observe it so closely that you can detect with your mind the beginning and the end of the pain. And it's, of course, it takes a great deal of work, but it's quite an empowering process to cope with pain on your own by training your mind to observe it. So some types of pain can be worked with this way. And of course, we're not talking about cancer pain. We're talking about more of those dull chronic pains that many of us live with. And physical activity. So, I mean, I've done yoga for 30 years. I've had a very strong practice, and I can say from my firsthand experience, as well as the experience of the many people that I've been with in this practice, that certainly you can alleviate pain through the practice of yoga, moving your body in gentle ways under the guidance of a teacher or a physical therapist. So a little bit about these types of opioids that we'll talk about more last time. Again, opioids take a lot of forms. Original opioids like heroin stemmed from the poppy plant, and someone in another class reminded me of Dorothy in The Wizard of Oz falling asleep in the poppy patch because they contain opioids. Not all poppies do, of course, but some particular poppies do. And so just like Dorothy fell asleep and almost couldn't be wakened, well, that was the effects of the heroin, or the heroin is derived from those poppies, from the opioids in the poppies. And they can also cause nausea, severe itching, euphoria, a very, very happy state, and then breathing problems. So all of these things can happen with heroin. And similarly, prescription opioids can very much have the same effect. This mental confusion seems to be something that's more aligned with these prescription opioids. And of course, a great deal of pain relief. So they're very similar, actually. This next little video, once again, you should stop and watch it rather than listen to me talk about it. This is describing how the virtual reality can be used to help people get relief from pain. So opioid abuse, of course, I don't know if you could live in this country without being familiar with this problem that emerged when pharmaceutical companies, in particular Purdue Pharma, aggressively marketed new type of painkillers, OxyContin, oxycodone, to doctors who treated, say, back conditions or other kinds of pain. And the pharmacy companies told the doctors that these were not addictive. And these became heavily overprescribed. And they were in fact addicted, and people who were prescribed these generally for chronic pain, something like back pain, very, very easy to become addicted and then begin abusing these drugs that were being prescribed so readily. These data are from a few years back. We will take another look at this. And you can see the number of deaths increasing so very much over the last couple of decades. It's a worse condition now, as you probably also know, and we have the insertion of fentanyl into the equation, and these things, again, we'll address next time. We also know that COVID-19 marked a dramatic increase in overdoses, so subsequent to this chart. So monthly overdoses increased during the pandemic. For example, May 2019, 10, if there were 10 overdoses, then there were 14 by May 2020. And so this is like quite a significant increase. We'll look again at these data more closely too in our next lecture. Pharmaceutical companies have been held responsible, but perhaps not enough. You'll catch a bit on this in a documentary that I'll share with you next time also. But we want to touch on it here because pain is the source of it. So you may have heard about cannabis as an alternative pain relief compared to opioids, and we know that cannabis, or in other words marijuana, weed, is now legal in many states, including Arizona and I believe New Mexico. And so how does this work for involving chronic pain? Well, we do have increasing use and positive results both from cannabis as well as CBD, which is an oil derived from cannabis. So not appropriate or beneficial to a person experiencing chronic malignant pain with something like cancer. But duller chronic pain that a person can still kind of live with, but it's really impeding their life. This is the kind of situation where there may be some benefits with cannabis as a medical treatment. So how do cannabinoids work? They work by blocking pain from peripheral nerves. So it's simply in that mechanism, which is different from the mechanism of opiates, which mimic the endogenous opioid system and sort of replace that. So that's two different mechanisms. And what are the results for chronic pain? Well, I'm describing here to you a review of a number of studies on this by Lynch and Campbell. And they had showed that cannabinoid was more effective than placebo in reducing pain in chronic pain conditions. And the conditions they studied included these: neuropathic pain, chronic pain, rheumatoid arthritis, fibromyalgia, and multiple sclerosis. And they did all that without adverse effects. So this seems like a pretty promising result for chronic pain. For acute pain, the results are less promising. There was no effect on dental extraction, post-operative pain. It was no more than effective than codeine in relieving pain, and thus it is not recommended for acute pain. So move on to our next content, mirror box therapy.